Morning, everybody, and welcome to our Thursday presentation. Today we have a neurologist presenting to us, Dr. Treasure Makgoga. He's a specialist neurologist with experience in a broad range of neurological conditions, including but not limited to multiple sclerosis, stroke, epilepsy, neuromuscular, and nerve disorders. He has a particular interest in autoimmune neurological diseases. He graduated from the Colleges of Medicine of South Africa in 2023 and continued in the academic department as a consultant, gaining further experience while working on his dissertation on TB meningitis at Sefako Makgatho Health Sciences University. Dr. Makgoga is passionate about teaching and enjoys sharing his knowledge of neurology with both undergraduate and postgraduate students. Thank you so much for coming to present to us. We're lucky to have you.
Thank you very much. Happy to be here. And we're going to just have a nice talk on status epilepticus and what comes beyond that. Just for context, this is how we're going to run. Just look at the definition, etiology, investigations, management, and we'll touch on mouse and fires as a subset of that status epilepticus. So looking from the International League Against Epilepsy, the definition of status epilepticus itself looks at a prolonged seizure that goes beyond 5 minutes. We know that previously it used to be 45 minutes, then it was brought down to 30 minutes, then it was brought down to 15 minutes. And then, but at this point, if any seizure goes beyond 5 minutes, that is taken as status epilepticus. Or if you have recurrence of seizures without the patient regaining consciousness in between the seizures. So I put there T1 and T2, which is what the International League Against Epilepsy looks at in terms of functional definition, that T1 refers to the time when the seizure does not self-terminate. And beyond that, it means that it has failed the mechanisms for the body's ability to terminate the seizure. Or there has been a problem with initiation of mechanisms that result in a typical prolonged seizure. And T2 refers to the time when a seizure itself has long-term consequences, including neuronal injury. But obviously, in terms of clinical approach on the ground, it's easier to look at prolonged seizure, more than 5 minutes, recurrence of seizures and without regaining consciousness in between. Refractory status epilepticus, on the other hand, is beyond the status epilepticus. So since once you have a seizure that continues despite using 2 appropriately dosed anti-seizure medication, meaning a benzodiazepine and a non-benzodiazepine, then that patient is in refractory status epilepticus. Further, if you have treated then with this anti-seizure medication, both benzos and non-benzo, and you put now the patient on anesthetic drugs, and on trying to wean the patient off from the anesthetic drugs, the patient then continues to have seizures, then that patient is in super-refractory status epilepticus. We'll speak about NOS and fires a little bit at the end, but just to give a definition, then we'll come back to it. NOS is a clinical diagnosis for presentation of refractory status epilepticus in a patient who has not been diagnosed with epilepsy or any other neurological condition. So this is a patient who's presenting for the first time in refractory status epilepticus. So NOS refers to new onset refractory status epilepticus. And there is a subset of those patients who present with a febrile disease, febrile-related illness, and it is called fires. We will come back to this. So looking just at the status epilepticus itself, unfortunately in South Africa, we don't have good data in terms of epidemiology as to, in our adult population, but a few of what we have is from the pediatric population that has been studied better. But the European and the North Americans, they have an incidence of 9 to 40 per 100,000 population. And children and older adults are the most, affected or the most susceptible to status epilepticus. In the literature of incidence that has been published, African Americans are more affected than when you look at the whites and the Asians and the Hispanics in that order. The males tend to be more affected than the females, and the health, but even though the males are more affected, with females, you tend to get recurrence. So just to give an incidence of a feel of how the children and older adults, with incidence of status epilepticus, it's you have about 15.5 per 100,000, in the age more than 60 to 69 years of age, while those with an incidence of 25.9 with a much older, which are above 80 years of age. Status epilepticus, it is a clinical diagnosis. So our diagnosis is based on what we see clinically, what the patient is presenting with. You do have phenomenology that could assist us in terms of presentation. You do have those who are presenting predominantly with motor features, and there are status epilepticus that can present without any motor clear or obvious motor manifestations. So as we see in our, this it's an extract from an article in 2023, they showed nicely that with the motor manifestation, you can have convulsive, myoclonic ones, and you can have, ictal paresis. You can have really the tonic type status epilepsy. The non-motor ones, you can have non-convulsive status epilepticus with patients with coma, and this is sometimes what we refer as subclinical status epilepsy. The role of an EEG in status epilepsy, as I said, that our diagnosis is mainly clinical. In the non-motor type status epilepticus, EEG can be used or is mandatory, especially, for the diagnosis there. But with the motor features, we use it as a confirmatory, but obviously the diagnosis is mostly clinical, as we've mentioned. Up to 15% of our ICU patients with impairment of consciousness of unclear cause may be having non-convulsive status epilepsy. So in this case, then EEG is of utmost importance, and a considerable proportion of those patients with convulsive status epilepsy can show ongoing ictal activity, then necessitating the use of the EEG in this case, even though clinically it might look like it had helped. Thank you. Treatment of status epilepticus is multimodal. You can have diagnostic and therapeutic parallel running together. So you do not wait for the diagnostics or wait for investigative processes before you start the treatment for status epilepsy. And it's multidisciplinary, so you can actually start the treatment pre-hospital. And then in the emergency setting, you can involve a neurologist, a neurosurgeon, and a clinical neurophysiologist, and a neurointernist, depending on what you have on the ground. Right, so this is a flow diagram that could help, in terms of managing status epilepsy and looking earlier on with status epilepsy. We've mentioned that anti-seizure medication, especially your benzos and your non-benzo type anti-seizure medication. So just to go through this flow diagram, what we usually look at is to stop the seizure that is happening at that time. Benzos will be your best or your front foot. You have an option. You can use lorazepam. You can use diazepam in that setting. Here it shows a calculation, but usually if you can just use lorazepam at 4 milligram at that time of the state of aborting the seizure, then quickly followed by an anti-epileptic medication like Epilim or phenytoin, or levetiracetam as we have now, then always what you want to do is you stop the seizure and prevent recurrence of the seizure. So the benzos in that case, for example, I was saying one could start with the lorazepam, give and then load immediately with epilim or sodium valproate as we showed there. So this sodium valproate, our loading dose, you can start at 20 milligram per kg. You want to put it in 200 mils of normal saline running over 20 minutes. The advantage with this sodium valproate is that it doesn't have side effects, so you can run it quickly over 20 minutes. If you have then a recurrence of seizure, in that case, you can give the lorazepam again. You still have another 20 milligram per kg of epilim that you give. Other options, you can give phenytoin. In this case, the one thing to remember about phenytoin is that it's cardiotoxic. So you want to give it much slower than epilim, so at least over 45 minutes, or you could use a calculation of 50 to 75 milligrams per minute. And also just remembering that with the phenytoin, you tend to have crystallization if you were to use it in glucose-containing fluids. Levetiracetam, what we have in the literature is that you can give up to 4.5 grams for aborting the seizure at that time. So having tried this first line and your patient continues to have seizures, then you're going to say, now my patient is in refractory status epilepticus. So now you want to start thinking about infusions, especially you can use midazolam or propofol. And you want to continue, obviously, your anti-seizure medication, even when you are giving your anesthetic drugs in this case. Just remembering that, this propofol and midazolam, they do have side effects. So you want to try to, give them within a certain time. For example, when you look at propofol, if you go beyond 5 milligram per kg for more than 48 hours, you start having to worry about a propofol infusion syndrome. In terms of efficacy, I've looked in the literature between midazolam and propofol. It seems like they are of the same efficacy. There is an advantage of giving them together, especially in patients where you've given either of them and you now tried to wean off and the patient continues to have status epilepticus. So now at that point, you would have moved to suprarefractory status epilepticus. So at this point, one can try a combination of midazolam and propofol together. Ketamine has been tried. You can also include your thiopentone and phenobarbital, but then your side effects in this case then start becoming a challenge. So as I was mentioning with the suprarefractory, there are no clear trials that have been done specifically to say which treatment is actually recommended when you are in this state of suprarefractory status. You could repeat the previously used anesthetic, or you can do the combination as we've mentioned. Ketamine have been tried. Gases also have been tried, but also the side effects are a problem. In the young or in the pediatric age, ketogenic diet have been shown to have some effect. A quick touch on the new onset refractory status epilepticus. We've mentioned that this is a presentation of refractory status epilepsy in patients who have not been diagnosed with epilepsy before or without any clear acute or active structural toxic or metabolic causes. So we mean that within the first few hours of your presentation, at least 24 to 72 hours, you have tried to manage, you've done the investigations that you could do, MRI, your blood workup, and at this point, you haven't identified anything that could explain why this previously healthy patient has gone into status epilepsy. Now, of these, the known etiology are not found easily within the 48 hours, but one you want to look out for on MRI, acute stroke, masses, drug overdose that could explain that. Most of the time, or the commonest of causes of this new onset refractory status epilepsy epilepticus is the autoimmune encephalitis, whether you're looking at sporadic, paraneoplastic, autoimmune type encephalitis, or uncommon infectious encephalitis. A subset of these patients with new onset refractory status epilepticus might present with fever that precedes the onset of the seizures. Usually the fever might be there between 2 weeks and 24 hours before presentation of the seizures. The epidemiology of this, not also well studied. This is sort of a relatively new entity, but it's something that has been seen, especially in the young adults, in the school-going children. It tends to have female predominance in the adults, and it's reversely the children tends to be male predominance. If you look at this, it tends to point towards autoimmune, diseases, but they tend to be more common in the females. Presentation of new onset refractory status epilepticus is generally non-specific. Patients might present before with a mild illness of gastrointestinal disease or upper respiratory tract. You can have fever. Not all of these patients, about 15% of the patients might present with the fever. Seizures are initially infrequent, but they progress quickly within a few hours to days towards getting into status epilepsy. EEG in this case tend to be, variable. You can have periodic epileptiform discharges. They could be lateralized, they could be bilaterally lateralized, it could be multifocal, it could be frontal or temporal. Really non-specific, nothing that could, point specifically to nose. MRI itself, you might get some T2 or flare hyperintensities in the limbic or neocortical areas. The CSF also not too specific. What you might get there is mild phagocytosis or raised proteins as well, usually mild. Treatment tends to be very difficult in this subset of patients. Anti-seizure medications, generally the response is poor. 75% of these patients will require anesthetic drugs at continuous infusion, but so initially, this is an algorithm I took for an article from 2019. I thought it could help that initially, obviously, these patients, you looked at them through the eyes of status epilepsy, but as time goes by, then you're going to move into refractory status epilepticus. And if there is an identified within the first few hours, if you are able to identify the cause, then it becomes a little bit easier in terms of management. But most of the time, you might find that it becomes cryptogenic, meaning the cause is not necessarily identified. And in this case, then once you have this patient, you've been sitting with the patient for at least 72 hours, your investigations haven't shown anything that you could specifically treat or could have provoked the status epilepsy. You've given your anti-seizure medication, you've given your anesthetic drugs, and when you try to wean off, then the patient goes back to having status epilepsy, then you're going to say you're in new onset refractory status epilepsy. So now you have to come with immune modulatory type treatment. Prednisone has been shown to be effective. IVIG, plasma exchange in this case, are considered the first lines. Usually, prednisone, one could already start it together with the plasma exchange if you are really worried in this case, in terms of buying time. Knowing that the plasma exchange, your side effects also can be a challenge with a patient already who has been on anesthetic drugs for a while. In terms of hemodynamic stability, that can be a challenge, but you do get good response to this. Having tried this and given full doses, and you have still struggling with seizure with the seizure presentation, one could try second-line therapy, which will, in this case, include things like rituximab, cyclophosphamide. Anakinra has been tried as well, cannabinol and ketogenic diet, as we mentioned, though in adults it tends to not necessarily have good effects. In children it has been shown to work, and that is the brief of it. Thank you so very much for listening.
Thank you so much, Treasure. That was really quite a great presentation. I just got one simple question.
Yeah.
The prognosis of subclinical seizures.
Prognosis of subclinical
mortality.
So with subclinical seizures, prognosis, one would look at the EEG especially. I would lean towards the EEG pattern, what it shows. So what we know with the EEG patterns in status epilepsy is that if you are having things like alpha coma, if you're having, burst suppression, that is not induced by the physician, because a burst suppression, if we induced it with the drugs, then it's a good thing. Then that speaks towards poor prognosis. And beyond that, I don't know, maybe if Dr. Kirsten has something to add.
Can I come in? So this topic of non-convulsive status epilepsy, what you hinted, non-convulsive status epilepsy.
Or subclinical.
So it's minimal or no clinical signs, and then you have the seizures. So that's probably what you're seeing most of the time in the ICUs. Now, that is totally different to generalized tonic-clonic seizures.
Yes.
Sometimes it can evolve between one into the other, where you start off with a generalized, you think you treated it, and then the patient doesn't wake up. So the prognosis depends on the etiology. So is the underlying cause reversible or not? So if it's a patient who drank themselves silly, then maybe just giving them time, they will recover. But if there's a background problem, if you've got your renal failure and liver failure and sepsis and disruption of the blood-brain barrier, those patients tend not to do well. But there was recent, Europeans are good, International League Against Epilepsy. One of the guys there was saying, anesthesiology run ICU units. So in Europe, one of them had a criteria: after 5 days, if the patient doesn't recover, they sort of call it a failed case. But he believes that's completely wrong. They've got patients who recover after weeks, many weeks. So if it's non-convulsive status epilepticus causing the coma, and all the metabolic things can be attended to, then you have to wait it out. Even if it takes 6-8 weeks, you have to wait it out.
Yeah, no, thank you. Yeah, because I think we had a lot of this discussion. I think when I was in Joburg General Hospital for picture, and actually I took out homework to actually start studying about the non-clinical seizures. And actually the problem that is not, I think if the issues about that are, as a physician in ICU, there is no substitute for thinking. So that means someone needs to be picked up and treated. And it progresses for more than 72 hours, mortality increases to almost 50%. Because it's subclinical, not diagnosed and everything. That's why in ICU critical care, it's always, you have this sedation holiday, where somebody at 5 o'clock in the morning, you need to stop your sedation and see whether your patients are awake or not. And if they're not waking up, then there's a room to do an EEG, a question whether it's EEG or 24 hours, but that will be normally determined by neurologists. So it's always very important that as a critical care specialist, you should always think about it, because the mortality can be very high. Because you know what, generalized seizures, tonic-clonic, we all know that. We all jump into it. The question is not about that. The question, I think, in critical care is to think about subclinical. And I mean, I remember very well a patient that we currently have in ICU. Out of blue, she's awake. You understand? So it means somehow you have to think about it, because the mortality can be high if it's not treated. Okay, and there's no markers for them apart from EEG. And even your markers, I mean, you haven't discussed about the acute markers of the epilepsy, because in the past, when someone got with the syncope and you're not so sure whether is it epileptic or non-epileptic or other things, obviously very few biomarkers that we do in ICU, because today due to every meeting, we see a lot of emergency physicians who are actually listening to this presentation. And I always say that if you have a patient come from with a syncope, there are very few tests that you need to do, obviously based on your history. In terms of epilepsy, I think, I don't know, Kirsten, you've been probably more senior about the role of prolactin in diagnosis, and then of course CK you also in diagnosis, and I don't know what other biomarkers there apart from the physician-based ones.
So the CK, if it's very high, it's diagnostic. If it's mildly, it doesn't really help. Prolactin only helps if you have a baseline prolactin. So if you're suspecting like pseudo seizures, so then you have a baseline, and the moment that patient has a seizure, the bloods must be drawn, and then if you clear a spike from that, then you can use it as a marker. But again, let's say it's not, you can't use it for high diagnosis, like as what's the word, like a high quality of diagnosis. It'll be
Evidence.
and the other thing you can see is like low CO2 levels and stuff, PCO2 levels and things during seizures and stuff like that. But those are smaller changes. Sodium changes, white cell changes. So the problem is we have a patient who loss of consciousness and a white cell up. You don't know in that first 24 hours, was it because of the seizure or was the infections? Only when you repeat it then afterwards. The other comment was with the non-convulsive status. So sometimes it's under-recognized. But and then even if you recognize, we tend to over-treat it. So even our Keppra can be neurotoxic. So if you have an old patient and we started giving Keppra and the patient's not waking up, and you've got no other, you can't keep blaming the non-convulsive status. It might be the drugs that are now causing toxicity. So then you have to actually come off it. That's the other issue with medication. Then with the patients with the non-convulsive status, same thing applies. Quicker the treatment, the better the outcomes. So you like to use your ketamine, your
Catechol, yeah.
So it's actually
It's a good habit.
So on those algorithms you have it as two separate choices, but you can actually use them together, and it makes theoretical sense because propofol works on GABA. So when the longer you have your seizure, your GABA receptors get internalized. So they become your GABA acting medications become less and less effective. NMDA. So if you combine the two, one inhibitory and one stopping the excitatory, it does theoretically it hasn't been proven, but it makes theoretical sense.
But practically also on that flow diagram, we've got the propofol and the midazolam.
Yeah.
But generally, practically, it doesn't always work because these are not patients that are necessarily young patients. With often in critical care, it's sick elderly patients, they've got renal failure.
Yeah.
And if you're going to give the midazolam and the propofol together, you're going to have hypertension. It's going to struggle
the propofol infusion syndrome becomes a problem in that case, of course.
So then to use ketamine for that reason as well, it's easier, it's more practical.
And for your blood pressure too.
But thank you, Kirsten. I think for me, the pathophysiology that you highlight about the MD receptors and the gamma pentan receptors, those are very, very crucial. How you actually start, because I think you go back to basics, physiology always played big roles in that. And then, of course, the other questions that I have for you, we had a patient that was sent from one of the peripheral hospital, they have failed in extubating the patient, had a prolonged ICU, so they tried twice and the patient was re-intubated. And I remember when the patient came and I asked Kirsten to do an EEG, and during the EEG found that he was having subclinical epilepsy. And then after 24 hours of treatment, we were able to extubate him. So sometimes I think you have to think about it. So it's a very crucial topic that in critical care physician is very important to kind of really do that. And sometimes you find that they actually present to EC and then they difficult to respond. And people tend to look at sometimes they look at the PCO2, then this is a tight respiratory failure because of the problem that they haven't been breathing. That's the only issues. And sometimes the PCO2 looks like the secondary thing. Yeah, but thank you so much for presentation. Guys online.
How often do you guys see propofol infusion syndrome? Because it's always listed, but they say it's mostly more in peds. I think we've seen it once in the last few years. Other risk factors.
I think we saw only once or something like that, but it's not very frequent. Yeah, also depends on the dosage of propofol that it goes. We have always used between 5 to 10 mils per hour infusion. Not only, and isn't that, we never gone really about 25
The problem is that's why some of those patients are actually underdosing them with that 5 to 10 if you work it out according to that dose. But even then, they say even in other units where they're using the proper dose, high dose, it's not commonly seen. It's more in the peds, so we shouldn't be scared of.
No. Yeah.
I think it's especially where you do have comorbidities like diagonal failure that you would worry about, and other things that can predispose the patient to like take acidosis and things like that. But yeah, it's not that common. It's just that it's one of those that gets highlighted a lot when you read about propofol as if it's quite common, but it's not that common at all.
Yeah. No,
that's the question. So, non-convulsive seizures, get some sort of measured at 5 days is kind of diagnosis of the brain failing or brain recovery.
So some people, it depends on the etiology. If it's like hypoxic brain damage and stuff, structural issues, probably not. But if it's a metabolic thing that can be reversed, let's say someone with acute renal failure and sepsis, and then the physician sort that out, and in the interim they just had a low level of consciousness due to non-convulsive status. Over time, if that's treated, they have an okay chance of recovery. So not it's maybe guarded in the sense that you can't make that decision that, you know, because you haven't woken up after 1 week, then you sort of a poor prognosis. So it depends on the cause. So as long as it's a non-structural cause, then your chances are, let's call it, maybe guarded.
Okay.
Just online, quickly, I'm going to give you guys opportunity to ask questions. But next week, Thursday, we have an ethic presentation by Prof. Ackerman from University of Victoria, and it will be on Thursday. So please, everybody want ethic point, please come join at 7 o'clock online. We're going to have really quite a lot of people attending. Prof. Ackerman is very, very great, and she'll give us one of the greatest presentation. Please make sure that you join us on Thursday for ethic point. Can we have any questions online to Dr. Treasure, please? Any other questions?
Everybody happy.
I think the question was raised by people, so that if they give their MP numbers, then they receive CPD points for this.
Yeah, they should receive CPD point. I'll speak to Sanet now, but I think there should be CPD points.
This is registered for CPD.
I think it is. Yeah.
I don't know about the
Okay,
Wednesday, we'll double check.
Well, we have Wednesday is done, Tuesday is done. I think Thursday, I'm not so sure, but let's see.
Wednesdays are definitely.
Yeah, but what happened that we can credit them later. They might just put their stuff, we can credit them. We'll apply for it.
Okay.
Yeah. Maybe I'll ask one of the lab to sponsor it. Thank you. Okay, if there's no question, thank you. Thank you very much. And thank you, Treasure, for the lovely presentation. Leanne, do you have anything?
Thank you, everybody.
Thank you.